to this afternoon's discussion on the fictional case of Child's Play. So, observations, where would we like to start? Andy? All right. Well, initial focus is on Andy. And with the disclaimer that I am not a child psychiatrist, and make sure that we understand that anything we observe in Andy, I'm going to really bring to the adult level. But what did you say?
Well, I thought it was interesting how they kind of jumped to like inpatient hospitalization for him when I believe he's 6 years old or just turned 6, and I do, from my knowledge of developmental, developmental science, I think it is still normal for children to have like imaginary friends at that point. So, and especially after the traumatic event he just witnessed for someone falling in his house out of a window, I was a little shocked that they would jump straight to inpatient hospitalization and saying that he had some sort of acute psychiatric illness.
Yep. So again, let's take the observation and let's just to kind of translate it or bring it to an adult patient, may or may not be named Andy, who presents. Following your psychiatric assessment, you recommend inpatient psychiatric hospitalization. What were your clinical findings to support your dispo planning? This is likely to come up on a test. What would it take for you to actually make such a recommendation?
Suicidal, homicidal ideation?
Yes, that's number one, right? So I'll put words in your mouth. So that the individual is demonstrating imminent danger to self or others, right? With SI or HI being but one example. What are some other examples, by the way? Less likely to come up on a test, but very likely to be seen in a clinical scenario.
Maybe engagement in like risky behaviors, like risky drinking and driving, things like that.
Mm-hmm. Mm-hmm. I'm still going to put that in the same rubric. Risky behaviors, imminent, yeah.
Maybe if they're refractory to treatment that's already been initiated?
So I think that comes next in terms of addressing the initial question, but maybe not quite the one that's currently on the table, that is imminent danger definition. How do we operationalize imminent danger other than suicidal or homicidal ideation? Or let's say suicidality goes beyond ideation, but that captures. It's an inability to care for oneself, right? That's the other biggie, right? So a person could not have any suicidal thoughts, not have any homicidal thoughts, but still warrant referral to a level that is no less restrictive than inpatient psychiatry if they demonstrate an inability or incapacity to care for themselves, satisfy their basic needs. All right. 3 examples of those areas that routinely come up, and there's several examples, but what are the 3 that come up, specifically the 3 that are listed on the State of New Jersey's commitment form? Basic needs in what areas? Hygiene, close. No.
Food?
Yeah, so that's one. Nutrition, right? Sorry?
Shelter?
Shelters, too.
Finance, you said.
Finance is not one of them, no. The other medical necessity. Medical necessity. Right. So those are the big 3 that come up, at least listed on the State of New Jersey's commitment form for involuntary hospitalization. All right. Any apply here? Now we'll take it back to our fictional case.
Food, maybe?
Food?
Well, not really. I just thought because he was making his own breakfast in the first scene. That it was supposed to be a nice thing, so.
And if the answer is no, we still have another part of the conversation to address is, okay, so even if Andy Barkley isn't an imminent danger to himself or an imminent risk to others, he might still rise to the level of care no less restrictive than an inpatient psychiatric facility. So what are the other criteria for inpatient other than imminent risk? You understand how we got here, right? Mm-hmm. Right? And I think somebody brought it up before. That's the biggie.
Oh, like previous treatments.
Yeah.
Successful.
Yeah, and it's a very broad stroke, but it's a good idea to start from the position of, well, anytime outpatient care is failing, right? It's absolutely well within reason to consider a higher level of care when your outpatient treatment plan isn't working. So now, what does that mean? Well, there we can get into more patient-centered details, but I think that's the big, general, broad stroke. All right. So, what else about Andy?
His dad died. Maybe that caused some sort of trigger for him.
Again, in psychiatry, we always talk about what predisposes, precipitates, and perpetuates behavior, and that is an obvious predisposing factor. I don't know how long ago Mr. Barkley died, but it's not in the movie. It's not scripted. Well, it is scripted, but it's not in the movie. And at the very least, a predisposing factor contributing to his current behavior, right?
Surprisingly, he also looked, excluding the clothes, he also looked a lot like Chucky. Like his face and his hair and everything looked exactly like Chucky did. Like the doll, I mean.
Who looked like the father or Andy?
Andy.
So they look like him?
Yeah, he looked exactly like him. So I feel like, I don't know what he was doing, but I think he was transferring the blame. If you're not thinking of it supernaturally, he was definitely transferring the blame because there's no way a doll comes to life and kills people. So if you think of it in that way, either he was committing all of these and then he just blamed the doll. Don't know why, don't know what exactly triggered him or who taught him such words, but also because if he's home alone and he's watching TV, he's been seen watching TV, you don't know if he goes from the good guys, I don't know if that's the name, good guys, to anything else. He could have been watching anything else on the TV as well, and he could have gone that sort of.
I actually didn't notice how close they resembled each other. Now I have to look more closely. But if so, and I have no reason to doubt you, if so, I think the reason is exactly what you uncovered here. Nobody in this room, if we're going to choose to view Child's Play through a psychiatrist lens, would think that a doll comes to life, right? So we could love 80s horror and 80s slasher horror as much as we want, and nobody in this room, in this hospital, in this county, and maybe in this state enjoys it more than I do. That said, taking the hypothetical situation where every one of my medical students chooses psychiatry as a career, PGY1, you're on call, and Andy Barkley presents to you with a history of present illness that is similar to, if not identical to, the plot of Child's Play. And I like I do with every single one of my residents and every single one of those phone calls, what do you think is going on? There's no chance you're going to tell me, well, Doc, the doll came to life, right? It's a zero possibility. So we have to consider that Andy is, in fact, the one who's aggressive, who is irritable, who's agitated, and who has a significant behavioral change, right? So.
Because I would like to point out that, because especially in the beginning of the movie, maybe in the later ones, maybe the mom got some shared sort of thing, but in the beginning especially, the doll would not speak in front of anybody else except him, so it does give that he's not delusional, but he's like, it's in his head basically, and he's hearing or seeing things, and if you don't take him as a child, I don't know, but I feel like because of the father thing and because of how alone I notice him being like isolated, I wouldn't say DID, but I know that he could be possibly dissociating a little bit and taking on the Chucky form because, like I said, he looks really like him exactly, and he's just, I think he mentioned to his mom that he said the father sent him from heaven to play with him, so clearly he remembers his dad, so I don't think the death was that long ago, maybe. And the Charles Lee Ray thing, you also see the TV switching to News 9 or something, so I feel like he could have easily found out information from that because, like I said, he probably has a lot of like thing with the TV exposure with all of that.
Other thoughts? So I think in kind of summarizing and putting some didactic to what your observations were, starting out with the normal, having an imaginary friend, believing dolls come to life is completely normal for a child until it's not. And that act is likely due to a defense mechanism. So when you have a daughter and your daughter asks you to tuck your dolly in, do not call me, do not call APS, do not call one of my brilliant first-year residents. Take a breath and realize it's completely normal, and the defense mechanism that they're utilizing, and it's probably two answers here, is what?
Sorry, what?
The defense mechanism that explains this normal behavior, that is developmentally appropriate behavior, is blank. So the one answer is fantasy, but the better answer, if you're asked on a test for the single best answer, is animism. Animism. So I think that's where we have to start here. However, there are people that are dying, and I'm not so sure as a psychiatrist we should just land on the initial spot and stay there. We probably have to progress by the consideration that this is developmentally normal, and consider that the doll has much more valence, much more significance than just another doll. Right? Beyond animism, if we think about this, we often use dolls with children to ask questions that are otherwise taboo, that they would have difficulty answering because they are a child. And the use of dolls in that situation might actually be kind of an interesting overlay here. That is, Andy's showing us things through his doll that he otherwise would not be able to show us, right? That's projection, right? That's projection, right? It's not unlike a therapeutic maneuver model where we use dolls to attribute our feelings, our meaning the child's feelings. Beyond that, we could have progression to an abnormal and disordered state. And there, I'm wondering if this is acting out. Now, this is more of a symbolic way because in acting out, it's the individual who actually demonstrates the behavior. But the symbolism of the movie is that the doll is doing the killing, not Andy. But we could still kind of have that under the umbrella of acting out. Right? So 3 defense mechanisms to explain the behavior we're seeing in some kind of progression from the abnormal to the significant, from the normal to the significantly abnormal. Questions about ego defense mechanisms in general, animism, projection, or even acting out in particular. Acting out is an observable behavior on an impulse. And it's usually to take one's awareness away from that rising impulse, that is, that impulse rising to conscious awareness.
Would you say it's some sort of a transference because he's blaming the doll for everything that he's possibly doing?
Yeah, I mean, I don't want to go off too much on a tangent with regard to transference versus displacement versus projection. At this point, I would just leave it at projection. What else about Andy? Anything else?
It was interesting that you said, I guess you were saying like a dissociative disorder. I mean, I was thinking just based off like a delusion. I mean, like, does it qualify as like getting into an acute psychosis type of disorder rather than a dissociative disorder, or it could be still a combination of the both? Because I guess he has delusions and hallucinations. Not sure about disorganized speech, but there's 2 of those kind of 3. So.
Yeah, and the way the DSM is set up to discuss the schizophrenia spectrum and the other psychotic disorders is primarily intended for adults. Right. So again, I think at first glance, when we think dissociation, psychosis, I think that there are initial considerations that we have to kind of process first, to formulate first. And I'd like for that to piggyback the previous conversation with regard to these ego defense mechanisms. If we are correct and identify his behavior as a product of these ego defenses, whether it's one, whether it's in some combination, what chapter are we likely to start out in here? The mere fact that we feel that his behavior is the manifestation of ego defense mechanisms. What are ego defense mechanisms, and why do we employ them?
Is it some sort of trauma?
Potentially.
I could cope with coping mechanisms.
Okay. I need more. You're right. What are we coping for? Anxiety. There's the chapter we start. Now, I could be completely wrong. This movie could have nothing to do with ego defense mechanisms, which means it has nothing to do with anxiety. But if we do have the conversation about ego defenses and we might be onto something, we have the something that is the most likely diagnosis. The starting point must be the anxiety disorder chapter of the DSM. And with that, and somebody said trauma, I'm going to include the obsessive compulsive and related as well as the trauma and stressor related disorders chapters too. There are 3 that come in sequence. Previous to 2013, there was a single chapter titled anxiety disorders. Now there's 3 separate. But I think all those diagnoses now are in play, at least to begin our formulation of what ails Andy Barkley. Right. So, any anxiety disorders appear to be in play here, and why?
He's pretty young. I don't really see any sort of very noticeable characteristics for anxiety for him. Seems pretty happy with his childlike self until all the murders start happening.
Anybody else?
What are the different types?
Okay, let's start there. With regard to the anxiety disorders, what are the different? I get to just repeat, put it in the form of a question, and ping pong it back to you guys. It's one of the great things having a long white coat. What are the different anxiety disorders?
General anxiety.
Generalized anxiety disorder, okay.
Social?
Social anxiety disorder.
No.
Panic disorder.
Acute. Well, I mean,
Like panic
that's,
attacks.
yeah, like acute stress.
So acute stress disorder and post-traumatic stress disorder are in the other chapter.
Oh.
Related, depending on our time, we'll get to them.
Adjustment.
Adjustment disorder also in the trauma and stress-related disorder chapter of the DSM.
Do specific phobias count?
So specific phobia,
Agora. Is that under
agoraphobia, good.
separation anxiety?
Separation anxiety disorder.
Is there something like a persistent something? No. Oh, that's depressive.
No, but persistent complex agreement disorder can be part of the post-traumatic and trauma and stress-related disorder spectrum. Yeah. I think not counting due to a medical condition or the effects of a substance. I think we might have one more.
Is it selective mutism?
It is. All right. So, what is selective mutism?
You often see it in kids, but it's usually when someone is not speaking in certain situations or refuses to speak.
Right. And how does that differ from mutism?
The situational nature of it.
Right. Selective mutism is a DSM diagnosis, again, specifically in the anxiety disorder chapter, whereas mutism is a clinical exam finding. It's something that you're likely to, if present, to report in the mental status exam. Right. So that is exactly what selective mutism is. Right. Generalized anxiety disorder. I'm just going down your list now. Generalized anxiety disorder. How would you best describe this? And describe it so that our peers can actually identify on a shelf exam.
Like feeling of impending doom.
Potential?
Didn't you say something about the
I don't
super
forget.
ego and the id?
I will always say this, but feel free to forget anything I've ever said. I want to know what you're going to say.
I remember what you said, but it was like, sorry, the super ego and the id have like some sort of friction.
Well, that's going to be true whether you have an anxiety disorder, whether you don't have an anxiety disorder. That, by definition, that's always in play.
Faster heartbeat or something?
Probably more panic disorder there. We'll get to that.
And you just have like worry about multiple subjects. It's not confined to any particular trigger.
Right. If you have to remember three things about generalized anxiety disorder. The first thing I want you to remember, and I almost want you guys to say it out loud and go around the room so you actually hear yourself say it. Generalized anxiety disorder has specific DSM criteria because a lot of clinicians don't really get that. Right? What a lot of clinicians instead do is have people present to them with clinically significant anxiety, work them up for multiple anxiety disorders, OCD, panic, etc., not be clear as to what's going on and default to, in their mind, what is a grab bag catch-all, which is generalized anxiety disorder, and that is not at all appropriate. Generalized anxiety disorder has specific diagnostic criteria, one of which is excessive anxiety and worry. What is the other?
Over 6 months, at least.
Also true, but that applies to all the anxiety, well, most anxiety disorders. The other one, basically, I think is chronic depression, because if you look at all the other signs, there is significant overlap with a major depressive episode. So anytime somebody presents with excessive anxiety and worry and a clinical picture that looks like depression, especially chronic depression, 6 months or more, generalized anxiety disorder is the single best answer. Questions about GAD? Social anxiety disorder.
Excessive worry about social situations, but not other situations.
Right? All right. The social or performance situation itself invokes the anxiety, right? And what is the most common example?
Like public speaking.
Yeah. Right. So much so that in 2013, the APA designated performance anxiety or public speaking as a specifier. Right. So just keep that in the back of your mind, and therefore it's likely to be the presentation on the case vignette. Agoraphobia.
Fear of not necessarily going outside, but being in like situations, environments that you have no control over, like airplanes are a common place for people that have agoraphobia.
No escape.
Right. Right. So that is definitely agoraphobia. Again, the idea here is that because of the difficulty of escaping or not being able to escape in time, the individual can become embarrassed due to onset of symptoms. That's agoraphobia. All right. Specific phobia.
There's like different subtypes, right? Just like fear of animals or insects or situational, environmental, blood, injection, needles, all of the above.
Right. So again, just repeating what you just said, which is correct. Specific phobia is an unreasonable fear that is clinically debilitating, clinically significant to an object or situation. And here, the APA has categorized 4 objects / situations, the 4 that you just named, right? So it's BASE, B-A-S-E, blood injection injury. A is animal. S is situational, and E is environmental. And if you have a fear of clowns and you don't fit into one of the 4, you have unspecified, which is the grab bag. Right? So unspecified does not fit in my acronym, so I'm not going to count it. Specific phobia. Panic disorder.
It's like a physical reaction to the anxiety or worry, I suppose.
And what does the physical reaction look like?
Traumatic episodes.
Tachypnea, tachycardia,
Which looks like what?
like rapid breathing, rapid heartbeat.
Heart attack.
Yeah.
Right? Any acute MI on a psych shelf is going to be a panic attack until proven otherwise. How are you going to be proven otherwise?
Tropes.
Right? Electrophysiologic EKG and or serologic troponins, evidence of acute myocardial ischemia. In the absence of that, it's going to be a panic attack. Recurrent panic attacks that are clinically significant, panic disorder. Right? If you look at the DSM criteria, you named a lot of them. It's a heart attack. Just remember an acute MI.
Is there a certain number you have to have, like within a time frame,
Yes.
to be qualified as insulin?
I think it's 4. I'm guessing no. I think it's about 4. The other part of this too, more a clinical pearl than it is a shelf exam question. A lot of people will come in with a chief complaint of panic, and never should you actually take that at face value. You should always make sure that your understanding of what panic is the same as your patient's understanding, and that is this is a discrete episode. Which usually peaks at 10 minutes and lasts for about 30 minutes. Now, of course, there's variation there, but I want you to have that in the back of your mind. The panic attack is to the acute MI. That anxiety in general is to angina. Right? So if you're not getting those discrete episodes, you don't have an acute MI, you have unstable angina. If you don't have those discrete episodes, you don't have panic attacks, you're having anxiety, right? So big difference, and the treatments are very different, right? And of course, if you have quote unquote just anxiety, you're back to the drawing board and figuring out why, right? Both in terms of a diagnosis as well as treatment plan. Right? All right. Any questions about panic? And the final one I've written down: separation anxiety disorder.
Fear of being alone for longer than anticipated situations. Codependency.
Mm-hmm. In the clinical vignette, there'll be evidence that it's separating from the house primary caregiver that induces the anxiety, not where the patient's going, not where the child is going. And the separation usually results in anxiety, which itself is going to be manifest not the way most of us would. I feel nervous, I feel blank. But instead, because it is a child, somatic complaints, so headache, stomach ache in the morning, every morning, upon separating from mom in going to school. Or behaviorally, right? Tantrums, murderous sprees in slasher films, and the like, right? How would somebody who is a test question writer make this the single best answer on a shelf exam? The very idea that the medical student reading the question closely understands that it's everything to do with separating from, not where they're going. How might that actually be portrayed?
Like, go ahead. Yeah, I saw your hand. Like going off of the school example you provided, like they could experience all that like somatic symptoms when they're in school. They get sent to the nurse's office frequently, but then as soon as they're home, they seem to be fine. They seem to have like a whatever normal affect is for them.
Yep.
Weekends,
Yeah.
I was gonna say weekends when the parent leaves.
Yeah.
That's the one.
What else?
There's like a varied amount of situations and places.
Yeah. It's exactly what we're looking for. All three of you nailed it, right? Across multiple social situations, the common thread is going to be where they're separating from. So it's very unlikely that the 15 times in the 15 different places over the past 2 weeks the individual has gone all somehow invoke the fear, when the common thread is where they're separating from. On the other hand, what if you get the signs and symptoms? What if you get that stomach ache and the tantrum before going to school, but when they leave the home to go to practice rec baseball, when they leave the home to practice dance, when they leave the home to do X, Y, and Z, nothing. What then?
Then you can like say that the school itself is like what's anxiety inducing.
Right, so you're going to cross A off
Yeah.
your list, and your self-exam you're looking at B, C, and D. What's going to help you differentiate B, C, and D in a general sense? And the answer is what the fear is. If you could ask your patient, what is the fear? If you get a reliable answer, you're going to get your answer B, C, or D. And then, of course, if you're looking over the answer sets, B, C, and D, you're going to go back to the case vignette and you're going to look for the exact information that's going to allow you to say, number one, the individual then, and now we'll put this as an adult, right? The individual then says that every time as a course director they get in front of that podium, the way that V14 room in the medical school is set up, the door's on the other side of the classroom, and if they ever got symptomatic, they would not be able to escape before becoming debilitated and embarrassed. Single best answer? That's agoraphobia. So I tried to trick you in terms of performance anxiety, right? But that's agoraphobia, right? If the fear itself, or if the fear is the social or performance situation itself, you have social anxiety disorder, right? Or if the fear itself is a specific object, maybe that is situational, or maybe even environmental, then what?
Specific phobia?
Right, so that's the way I want you to think about this, especially when taking your exam, right? Is it where they're separating from, or is it where they're going to? If it's separating from, we're going to call that separation anxiety disorder. If it's where going to, depends. What is the fear? Go back to the case vignette, specifically look for the fear, and then you're going to be able to choose the single best, B, C, or D. Questions about the anxiety disorders? If there are no questions, now you're going to tell me which one Andy Barkley has.
I'm confused between two because I think separation anxiety, now that you said it sounds like him, because his dad died as well, so maybe he got too emotionally attached to his mother. But I don't really see much of like that attachment. Honestly, by the independence he shows, especially in the beginning scenes, I don't really see it. But also agoraphobia, because he's scared of not being able to escape from Chucky's claws.
It's a fair differential. Getting back to your first consideration, which was separation anxiety disorder, when you said you didn't see, if we could get a hold of the writer-director and add to the script, what would you have preferred to see? To nail this as a single best answer.
Just like a common point thread of multiple incidents of just being separated from the mother and inducing that anxiety attack.
And how would the anxiety attack look? Because I didn't see Andy have a headache or a stomach
there
ache.
was no tantrums. Even on his birthday, his mom wasn't with him, and he didn't seem very like anxious about. Not even anxious. He didn't have any stomach aches or headaches, or honestly, he didn't seem very tantrumy. He seemed very normal. That's why I don't.
Well,
think
you just told me a little while ago that
Because
he
his-
killed 4 people.
Well, that's different. Like,
Is it behavioral?
Murdering?
Behavioral, or the murdering you will never see in a child with separation anxiety
He was murdered.
outside of an 80s slasher horror classic.
He was murdering even when the mother was present. So I don't really.
So I actually
No.
did the deep dive with this. Rewatching this movie, there are 4 people that die by Chucky. Every one of those deaths is a scene immediately after Andy separates from his father. Excuse me, from his mother. Right? So this is an over-the-top, very dramatic, very 80s slasher-esque depiction of separation anxiety disorder. So I've got the table set up for you guys. Anybody here on the Instagram group? No? All right. So, okay. I'll be sending it to you guys for post, just to review. Separation anxiety disorder is probably the single best answer here. Not somatic, behavioral, and behavioral only in a very fictional sense, only the way the 80s can do it. All right, and closing this discussion, any final thoughts or questions? All right, we'll leave it here. I will post next week's film sometime this afternoon, probably. All right, as well as the next week's